which is on the alcohol and the heart. The chairpersons for this talk are Professor Ritu Nehra, Dr. N.K. Sharma, and Dr. Shubhamohan Singh. Professor Ritu Nehra is a professor in Clinical Psychology, Department of Psychiatry, PGI MER. Dr. N.K. Sharma is alumni from our department. Dr. Shubhamohan Singh is additional professor in Department of Psychiatry, PGI MER, Chandigarh. Thank you, sir. Thank you, ma'am. Kindly introduce our speaker for today.
I think our co-chairperson, Dr. Shubhamohan, has not reached yet. But anyway, we started. Well, this session is on alcohol and the heart. When should a psychiatrist be alert? And Dr. Saurabh Mehrotra is from Cardiology Department, Additional Professor Cardiology. He's going to enlighten us about this topic, which is a very important topic for all of us. Dr. Saurabh Mehrotra.
Good morning, everyone, and respected chairpersons. I'll be speaking on alcohol and the heart today. When Dr. Basu invited me to speak on this topic, it was a Herculean task for me to contemplate as to what would be of interest to the psychiatrist in this topic. And in the next few minutes, I'll be probably taking you down to the memory lane and recapitulating a few basics that you learned during your MBBS days. Now, as we all know, that alcohol is a major drinking problem worldwide, and people can be divided into drinking categories as abstainers, drinking category 1, which includes patients who drink about 0.25 to 20 grams per day, category 2 and 3, which is high alcohol consumers, who consume as high as 40 to 60 grams of alcohol per day. Now, we all know that with increasing alcohol consumption, there's relative risk of mortality from coronary artery disease and other forms of heart disease increase. And individuals who consume more than 3 drinks a day have a high possibility of having high blood pressure, dyslipidemias, congestive heart failure, alcohol cardiomyopathy. So first of all, we'll be discussing about dilated cardiomyopathy. Patients who take alcohol chronically are predisposed to develop this kind of cardiomyopathy, and it is important to know that it is reversible. With abstinence, the LV function have a tendency to come back to normal. Continued use is associated with a 3 to 6 year mortality, which is pretty high, and hence it is important to be aware of this entity. So the exact mechanisms are still not known, but it is believed that acetaldehyde and the other fatty acid metabolites which are produced during metabolism of alcohol cause direct toxicity to the myocardium. Now, when a psychiatrist is sitting in the OPD and an alcoholic patient comes to him, how would he know whether the patient has dilated cardiomyopathy and whether the patient needs to be referred to a cardiologist? So from a psychiatrist's perspective, there are 4 things which are important. First is the history, next is the clinical examination, the X-ray and the ECG, which probably all patients have even when they walk into a psychiatrist OPD. Now, going on to the history, first of all, the psychiatrist should ask whether the patient has symptoms suggestive of heart failure. Symptoms would be in the form of dyspnea, that is getting short of breath while walking, or palpitations. These are the most common symptoms of dilated cardiomyopathy and should be looked for. Second, the patient should be asked for any history of chest pain either at rest or on exertion. Moreover, since the dilated heart is a poor contractile reserve, hence it is predisposed to formation of thrombus, and this thrombus can get dislodged, and the patient can also present with cerebrovascular accidents in the form of stroke, hemiplegia or paraplegia. And any alcoholic patient who comes to a psychiatrist with a history of CVA, again, the psychiatrist should be alert and vigilant to look for an underlying dilated cardiomyopathy. Other rare manifestations include syncope and sudden cardiac death. As far as the clinical signs are concerned, the pulse examination should be a routine, and features like sinus tachycardia or an irregular pulse suggestive of atrial fibrillation should be looked for. The blood pressure in these patients would normally have a narrow pulse pressure. The psychiatrist can always look at the jugular venous pressure, and if the jugular venous pressure is elevated, again it's a pointer to the fact that probably the heart function is low. And of course, the CVS examination I'm not discussing here. The other peripheral signs again which can be looked into is the liver. The liver may be enlarged, tender and pulsatile, and can be looked into. Then one should look at the feet to see for evidence of any pedal edema, which again is a pointer to the fact that their back pressure changes. one can always auscultate and look at the lung paces, and any fine crepitations in the lung paces again points to the fact that probably the patient is in heart failure and should be referred to a cardiologist to rule out an underlying dilated cardiomyopathy. Now, as far as the ECG is again important, and I presume that every patient who comes to the psychiatry, one or the other would definitely have an ECG with them. So the ECG can have varied manifestations, but I'll be discussing only the few prominent manifestations which one should look for to make a diagnosis. Now, going back to the basics, if you look at the ECG paper, you have one small box which is 0.04 seconds, and you have a large box which is 0.20 seconds. So that is how you have the ECG paper which is calibrated, and vertically a large box is 0.5 millivolts. So in general, whenever you look at the ECG, what is important is that one should look at the lead 2, because that is the rhythm strip and that gives you the maximum information. And first of all, in order to calculate the heart rate, the dictum is that you divide 1500 with a number of small squares between the RR interval. So that would give you the heart rate, and from that you can probably decipher whether the patient has tachycardia or bradycardia. So in this example, you have to divide 1500 with a number of small squares. So as you can see in this slide, there are about 15 small squares between two consecutive RR intervals. These are 5, this is 10, and then this is 11, 12, 13, 14, 15. So then the heart rate would be 1500 divided by the number of small squares between the RR interval, which is 15, and hence the heart rate is 100. So this is what a psychiatrist should know. One should be able to read the ECG, calculate the heart rate, and any evidence of sinus bradycardia or tachycardia should probably alert them. So this is an example of a sinus tachycardia because the heart rate is more than 100. Next, it is important to look at the rhythm. That is the next basic thing which one should be aware of. And one should look at the P wave and see its relation with the QRS complex. And also look whether the RR intervals are at regular intervals or whether they are irregular. To start with, one can even use a paper strip and map out the consecutive beats and see whether rate is the same further along the ECG. So one can mark the RR intervals on the paper, piece of paper, and then move the paper along the rhythm strip and see whether the RR intervals come at the same level or not. So the next common anomaly which is seen in the ECG in patients who have a cardiomyopathy is atrial fibrillation. So if you take a paper strip with the RR intervals marked, and if you map it along the ECG, you'll see that the RR intervals would not come at regular intervals. So if the RR intervals are irregular, it probably means that the patient has atrial fibrillation. The patient should be referred to a cardiologist, an underlying echocardiogram should be done, and probably the patient needs to be started on anticoagulants to prevent any complications like systemic embolism. Now, next important thing that one should look on the ECG is the P wave. Now, a normal P wave normally constitutes 3 small squares, and the height is around 2.5 small squares. So this is how you see a normal P wave in a normal calibrated ECG. Now, if a patient has a cardiomyopathy with left atrial enlargement, the patient would either have a bifid P wave like this, or the negative deflection would be more than 1 small square. So if on the ECG, the P wave is either bifid, or if the terminal deflection is more than 1 small square, then probably it means that the left atrium is enlarged and an underlying heart disease should be ruled out. And another important ECG finding, which is seen only in pathological conditions, is the left bundle branch block pattern. So one should be aware of the left bundle branch block pattern in which one gets an R pattern in lead. And whenever a psychiatrist sees an LBB pattern on an ECG, an underlying heart disease needs to be excluded. The most important thing on the X-ray is cardiomegaly, for which the CT ratio should be calculated, and it's calculated by measuring the maximum internal cardiac diameter divided by the maximum internal thoracic diameter measured from the internal rib cage. And if it is more than 0.5, it's a pointer towards cardiomegaly, and the patient needs to be looked for an underlying cardiac disease. Moreover, the pulmonary vascular markings can also be looked into, and if the pulmonary vascular markings extend till the lateral 1/3 of the lung feels, then again it's a sign of pulmonary vascular congestion. Now, another important entity which the psychiatrist might encounter in the emergency is holiday heart syndrome, which is normally seen in chronic alcoholics and is precipitated by binge alcohol intake. Though a number of arrhythmias can be seen in holiday heart in the form of supraventricular tachycardias and premature atrial complexes, but the most common is again atrial fibrillation, and hence the need to map the ECG strip to look for regularity of RR interval. Now, next is hypertension. As we all know, according to the latest guidelines, hypertension has been defined as a blood pressure of more than 140/90, and the alcoholics, besides due to other multifactorial causes, are increasingly predisposed to development of blood pressure. So the blood pressure should be measured in all these patients to detect hypertension. And ethanol has a causal importance in up to 11% of men and is normally dose related. And binge drinking is associated with substantial increase in blood pressure. And again, as for cardiomyopathy, abstinence in a few percentage of patients tends to result in normalization of blood pressure. So one thing is important is measurement of blood pressure in the OPD is very important, and a blood pressure more than 140/90 means that the patient is probably has hypertension. And the next important thing is that one should look at the ECG for subtle signs of increased blood pressure. And the most important thing that needs to be seen is the height of the R wave and the S wave. Normally on an ECG you have a QRS complex in which the Q wave is less than 1/4 of the height of the R wave, and the sum of the R wave and the S wave in lead V1 and V6 is normally less than 3.5 mm. Now this figure is important because one of the important criteria that we use for diagnosis of left ventricular hypertrophy on ECG is that the S wave in V1 and the R wave in either V5 or V6 is more than 35 mm. So if the S wave, if this is present, if the height of the S wave in V1, the R wave in V5, V6 is more than 35 mm, again it is important and one should rule out hypertension, besides of course other causes of left ventricular hypertrophy. Now, alcoholics are again more predisposed to coronary artery disease, and again history taking is very important, and if a patient has either dyspnea on exertion or chest pain on exertion, then an ECG should be ordered just in case it's not available with the patient. And subtle signs which the psychiatrist should be aware of in the OPD before referring a patient to a cardiologist is either ST depressions or ST elevation, which is a pointer to the fact that there's underlying coronary artery disease. So if there's a ST elevation of more than 1 millimeters in at least 2 contiguous leads, it's a pointer towards a myocardial infarction, and the patient should be immediately referred to the cardiac center. Moreover, subtle signs like ST depressions and T-wave inversions also point to the fact that probably a patient has unstable angina or a non-ST elevation MI, and these signs should also be looked in the ECG so that the patient can be referred at an appropriate time. Now, next is the QT interval, which is very important, and the reason is because patients who are on psychiatric medications are also on cardiovascular drugs, and they tend to alter the QT interval, and this alteration of QT interval can have arrhythmic consequences. So it's important that while the patient is on psychiatric drugs, the doctor in the OPD should have a constant vigilance at the QT interval, and the QT interval is normally measured in lead AVL, as it doesn't have a very prominent U wave. So starting from the beginning of the Q to the end of the T wave. So that is how the QT interval is measured, and all residents in the OPD should be aware of how to measure the QT interval, the relevance of which I'll be highlighting subsequently. So now the next important thing is the drug-drug interactions. A lot of patients, we know that alcoholic patients can have cardiomyopathy, can have CAD, can have arrhythmia. So these patients would be on cardiovascular drugs along with antipsychotic drugs. So their interactions should also be looked into before prescribing these medications. Now, out of the antidepressants, the first one is the serotonin reuptake inhibitors, which are commonly used. And it is generally believed that for heart failure, these drugs are safe. There's hardly any prolongation in QTC, and the risk of arrhythmias is rather low with these drugs. There's hardly any risk of heart failure, and then sertraline has also been shown to improve heart rate variability and has anti-inflammatory effects. So as far as the SSRIs are concerned, they don't have any disastrous effect as far as the heart failure is concerned. However, the only concern is in patients with coronary artery disease, because it has been seen that there's an increased risk of GI bleeding in patients who are on antiplatelet drugs and who are being given SSRIs. And the hazard ratio is maximum when the patient is taking dual antiplatelets vis-a-vis a patient who's on single antiplatelet agents. And prescribing a proton pump inhibitors in a patient who's on antiplatelets and SSRI tends to decrease the bleeding risk. So this is an interaction which is important to remember. The other antidepressants are serotonin norepinephrine reuptake inhibitors. Since they inhibit the uptake of norepinephrine, so hypertension is a side effect which is normally seen with this medication. Hence, patients who are on SNRIs should be monitored for blood pressure measurements. As far as the tricyclic antidepressants are concerned, tricyclic antidepressants are notorious for causing orthostatic hypotension. So any patient who's on tricyclic antidepressants should be evaluated in the OPD for measurement of blood pressure, both in the standing and supine position. Moreover, tricyclic antidepressants tend to cause an increase in QT interval. Hence, these patients are at risk of cardiac conduction defects and proarrhythmias. Hence, a patient on tricyclic antidepressants should have a QT interval measurement at routine intervals. The atypical drugs are by and large relatively safe. Now, going on to the anti-anxiety drugs, the benzodiazepines are considered to be relatively safe. The only drawback is that short-acting benzodiazepines should not be used. Important drug which is given in cardiovascular medicine is statins, and it has been seen that benzodiazepines, by inhibiting metabolism of cytochrome P3, A4 tends to inhibit metabolism of statins. So this is an interaction that should be looked into when a patient is on anti-anxiety drugs as well as statins. Now, not only do psychiatric medications have cardiovascular effects, it's also believed that cardiac drugs can also have psychiatric side effects, like it was long believed that beta blockers can cause depression. So I thought it is important to highlight the fact that through critical review of a lot of randomized trials, it has been shown beyond doubt that beta blockers does not tend to worsen depressive symptoms in heart failure patients. Now, going on to the typical antipsychotics, low potency typical antipsychotics like chlorpromazine, especially when given IV, is associated with orthostatic hypotension and QT prolongation. And as far as the high potency typical agents are concerned, like haloperidol, it is also associated with QT prolongation. Chlorpromazine tends to cause QT prolongation even when given orally, while haloperidol is more notorious when it's given IV. Now, the atypical antipsychotics are of interest because it's been seen that patients on atypical antipsychotics have a 2 to 3 times increased mortality from cardiovascular disease, primarily because they cause dyslipidemia, glucose intolerance, and weight gain. So, out of all the atypical antipsychotics, the interaction with quetiapine has been found to be the least. As far as the weight gain and waist circumference is concerned, olanzapine is notorious for causing the maximum increase in weight gain, while ziprasidone is kind of relatively safe. As far as dyslipidemia and glucose intolerance is concerned, it's worst with olanzapine. And of course, few rare cases of cardiomyopathy and myocarditis have been reported with clozapine. Actions between the psychotropic drug and cardiovascular drugs necessitating dose management. Though I probably feel that it is virtually impossible for anyone to remember all these interactions by heart, but I feel that all the residents in the OPD should probably have this chart with them, so that just in case any patient with coronary artery disease is on concomitant psychotropic drugs, they can probably refer to this chart and look for drug interactions and then decide on dose modifications. And as and when you keep doing it on a regular basis, probably it'll become a part of you. Otherwise, going through this table and memorizing it is virtually impossible. So I feel that this table is something that every resident should have with him in the OPD so that he can decide on dose modification, psychiatric problems. The overall recommendations when using both psychotropic and cardiovascular drugs is that one should carefully monitor blood pressure, especially in older patients. Avoid orthostatic hypotension, which could worsen angina in patient who has coronary artery disease as well. SSRI and atypical agents have few side effects and can probably be used safely with cardiac drugs. In patients with heart failure, avoid episodes of hypertension with drugs such as tricyclic antidepressants. Avoid tricyclic antidepressants in patients with heart disease because of QT prolongation. Intermediate to long-acting benzodiazepines can be used as anxiolytic in patients with concomitant cardiac drugs, but should be routinely evaluated for safety and efficacy. Buspirone is a non-habit forming anxiolytic that can be used long-term with no significant cardiovascular adverse drug events. Thank you.
Thank you, Dr. Saurabh, for a very comprehensive, educative. For the psychiatrist, I have been in this field for the last 39 years, and 25 years are exclusively independent, one-man practice. And the kind of education you have given to us about what is psychiatry and the heart and alcohol and the heart is very, very good, very nice. Thank you so much. The topic is open for questions and comments, please. Thank you. Please introduce yourself when you ask a question or a query so that others come to know who you are. Thank you.
Yeah, I'm Dr. Praveen, Professor of Psychiatry. I have two questions for you. The first is, a lot of heart rate reliabilities publications are going on, and they are impelling cardiologists as well as psychiatrists to write up for these SSRI kind of prescriptions. On the other hand, these SSRIs in hypertensive patients can increase, the chances of bleeding or strokes. So how do you actually conventionally balance this kind of
Well, the mechanism for both is different. Though SSRIs have a favorable impact on heart rate variability and hence should be used in patients with low ejection fraction and congestive heart failure and are safe, but because they have an anti-platelet effect and prevent platelet aggregation, hence when combined with antiplatelet agents, they tend to increase the risk of bleeding. So what one can do is that one can advise a PPI in patients whom an SSRI is to be given, as well as antiplatelet agents can be advised. And just in case it's a low-risk coronary artery disease patients, one can probably give a single antiplatelet rather than prescribing dual antiplatelet agents.
In the course of the prescriptions, is it the initial first 4 to 6 weeks which is at the higher risk of giving these vulnerabilities, or it's a prolonged period of time?
As far as the bleeding risk is concerned, the bleeding risk is prolonged. But as far as the risk from the heart is concerned, the first few months are much more important, especially the first 3 months, because the tendency for stent thrombosis is maximum in the first 3 months.
Thank you.
Very good morning. Myself, Dr. Sai, Resident Department of Psychiatry, GMCH, Chandigarh. So my question is, you mentioned in the presentation the JNC 7 guidelines. So in light of JNC 8, which came back in 2014, so will you kindly clarify that whether we have to abide by JNC 7 or 8?
Well, there's not much difference except for a few drugs which have changed. So the JNC 8 is to be followed currently, and the blood pressure, which is for diagnosis of hypertension, remains more than 140/90.
Okay. Another clarification regarding QT-C intervals, sir. Corrected QT. Since we have to get it calculated for patients who are on quetiapine and other psychiatric drugs, antipsychotics. So in that, that the QTC has to be taken from lead 2 only?
From lead AVL.
From the?
Lead AVL.
Lead AVL. Fine. Thank you.
What is your view on SSRIs and hyponatremia? SSRIs and hyponatremia. A lot of elderly people vomit, they're on SSRIs, they come in various altered states of consciousness. So it's whether to continue, not to continue at that point in time. Because many of the SSRIs also cause hyponatremia.
Yeah, so I think a psychiatrist would be in a better position to answer that question. But what I personally feel is that since they would probably have a long half-life, and if a patient has been on SSRI for quite some time, so probably one can discontinue at that point in time. Once the sodium recovers, it can be restarted.
Excuse me, please. Now, there's an important observation which has been raised by a senior colleague. The prevalence of hyponatremia vis-a-vis the psychological symptoms, the psychological and psychiatric presentations of the patient, and the only thing found is hyponatremia, which is supposed to be responsible for all the things that it has. I would like some senior psychiatrists to, Dr. Raj, yes please.
Can I just make one request? Let's stick to the topic, please. We are discussing art and alcohol. So please restrict yourself to the topic.
Okay.
Otherwise we get bailing.
Right. Yes.
So We are not going to get an eminent cardiologist like him again and again standing with us.
Yes.
So restrict your questions only to heart and the drugs if you want.
Right. Thank you.
So when you admit an alcoholic, there's a acute withdrawal because all of a sudden there's a withdrawal. In Punjab, once you admit alcoholic means he takes 1.5 bottle, 2 bottles a day. There is a sudden reactive hypertension. Is it risky? How to manage it? And what complication can be expected? Because in a normal patient, non-hypertensive patient, when the BP shoots up to 200 or near that.
Yeah, so all hypertensive emergencies have to be managed, and they can be as disastrous as increase in blood pressure in any normal individual. If a patient doesn't have a history of hypertension in the past, probably chronic baroreceptor resetting has not been present in that individual, and a patient who develops an acute hypertensive emergency in the background absence of background history of hypertension probably needs to be treated more aggressively than an individual who has a high blood pressure with a background history of hypertension. So no hypertension with acute rise in blood pressure because of alcohol withdrawal has to be treated more aggressively vis-a-vis an alcohol withdrawal hypertensive emergency in a patient who has already had an underlying chronic hypertension. And the line of management is the same. If the blood pressure is really high, say the blood pressure say above 200 or 180, then the patient has to be started on nitroglycerin infusion, and the dose has to be titrated so that the reduction in blood pressure has to be gradual. One doesn't have to attempt a drastic reduction in blood pressure in a few hours, because that can also have disastrous consequences.
Can you do something to prevent it?
Well, this is a consequence of an alcohol withdrawal. So if it has to happen, I mean, you cannot prevent it. I mean, it's a.
Can beta blocker help in that condition because it's the hyperadrenergic?
I think we'll wind up the session. Any other questions? I'm sure sir would be happy to respond after the session is over. So thanks a lot, sir. Thank you for your wonderful talk.
Thank you, sir, for comprehensive talk. I request chairpersons to kindly felicitate our speaker for the session. I request Professor Ajit Awasthi to kindly felicitate Professor Ritu Nehra, Dr. N.K. Sharma, Dr. Shubmohan Singh. Thank you, sir.